All right, guys, we are beginning for chapters 1 through 3. This will be your lecture, starting with chapter. You should see my screens on both recording software. I'm also going to put this up on my YouTube channel. So, chapter 1 is about EMS systems. You guys are already EMS or fire and have familiarity with our system and kind of what EMS does and how it is that the public accesses EMS. But maybe you don't know all of the information that's contained in the chapter. So, a good way to start off with the EMT course is to define what it is to be an EMS system. And so that's the intent of this chapter. So we'll go through what an EMT is, what an advanced paramedic is, what is med control, who kind of governs what we do, the general operations of EMS and how it is that we're allowed to do our job. I think it's pretty interesting and unique that EMS provides one the ability to do some of the things that only physicians can do with less than 2 years of training. Mostly speaking towards paramedics, there's not a lot that they can't do that physicians have to go to school for 12 years before they're allowed to touch people and do. And so that's one of the things that attracted me to this industry is that it was born out of necessity. What EMS is able to offer the people that we serve was born out of necessity, how to save as many lives as possible as quickly as possible. So when you look at the scope of practice that we're going to talk about later, and you're wondering, well, why is an EMT able to do blank? And why is an advanced? And why is a paramedic able to do blank? That was born out of the needs of the people we serve. What emergencies are going to kill people the fastest? And no matter what that answer is, that was the scope of practice. It became the scope of practice. And so that's pretty unique and interesting for pre-hospital providers that I don't think you'll find in any other area of medicine. For example, nurses can't do what we do. Some PAs can't do what we do. We really do have a unique provider modality that you can't find anywhere else. And so that's pretty interesting. And I think this chapter touches on some of those characteristics. So we'll get into that. Obviously, we're going to talk about the well-being of EMS providers. We're going to talk about what is EMS as a system. We're going to discuss our history. If you don't know where you come from, it's very difficult to know where you're going. And so that'll be a talking point of the chapter. We'll talk about quality improvement, so QA and QI. We review every single chart that we write on patient care. So supervisors and the medical QA community of your service is going to look at every single patient care record that's generated within the service and decide, not from judgment, not from is this a good EMT, a bad EMT, but from the perspective of, are we doing what we say we do? Are we providing the standard of care? Do we follow the rules in medicine that seem to dictate the best outcomes? So everything that we do in EMS is generated from science-evident medicine. In the old days, we did what we did because the physicians in the American Academy of Orthopedic Surgeons told us to. But as we advanced in EMS, we became our own thing, and we actually certified physicians that specialized in EMS. An interesting fact is that in 2010 was the first board certification of an EMS physician. 2010, guys. That was not very long ago. And so if you think about that, when we began EMS, we started doing what orthopedic surgeons thought we should do because we were mostly trauma-based. And so who more appropriate to get answers from than the people who dealt most with trauma, the orthopedic surgeons of that time. But now we have our own studies that look at our own environment. What was most successful in pre-hospital medicine? What was most successful in the field? So we have studies now that are specific to us. We have evidence-based medical journals that are specific to us. And so we take those standards that are created by science, evidence-based medicine, and we develop quality improvement programs. Basically, we look at all the patient care conducted in the service by our providers, and we say, did we meet the mark? Not in a negative way. You're going to see test questions that say, is QA/QI supposed to be negative? And the answer is no. The goal of QA/QI is only to build providers. If we're not meeting the mark, the question quickly becomes, how do we meet the mark? What training can we implement? What policy and procedure can we implement in order to meet the mark? So that's the goal of QA/QI. Not punishment, not negativity, but basically a measurement. Are we doing what we say we do? Okay, hold on 2 seconds. Everyone and their brother is trying to get a hold of me. Because I'm lecturing. That's the only reason. 2 seconds. Give me 2 seconds, guys. I'm going to step away 5, maybe 2 minutes. I'm going to go grab a receipt real quick. I'm going to be right back. 2 seconds. My apologies. Sorry about that, guys. So again, that is the point of QA/QI, and you'll see that in some quiz questions. And then obviously we're going to talk about safety. And the rule of thumb is typically throughout the entirety of this class, your safety comes first, then your partner, then your patient, then bystanders. And you need to follow that algorithm throughout the remainder of the class. Your safety comes first. So anytime you see a question that brings to bear the potential for you to be in harm's way, the answer would be my safety first, retreat, get out of harm's way, get a hold of law enforcement, get a hold of the resource that will bring you safety. You're not supposed to, as an EMS provider, in typical sense, put yourself in harm's way. So your safety first, always and forever, throughout the entirety of the course. I already talked a little bit about the fact that we are now science evidence based medicine. So We research what is successful in our field. We research what is successful in the medicine that we provide. We look at chest pain patients and say what betters their outcomes. Respiratory patients, trauma patients, sepsis patients. So these are the categories of patients that you're going to see areas that DHEC actually hires a coordinator for. There's an EMS sepsis coordinator. There's an EMS trauma coordinator. There's an EMS pediatric coordinator. Why do those people exist? They exist because those are areas of pre-hospital medicine that we've identified we can make a difference in those areas. In fact, one of the unique facts about our state is that Greenville Health System, their EMS in Greenville, South Carolina, actually piloted a large sepsis protocol that actually looked at resuscitation, fluid management resuscitation on sepsis patients, and asked the question, does a patient have a better chance of surviving who experiences and is identified to be in sepsis by EMS providers if they are resuscitated in a certain manner? And the answer to that question at the end of the study was yes. The people who were identified as septic by EMS and resuscitated in a specific manner with fluid resuscitation, the earlier that occurred, the less mortality of those patient populations. What does that mean in the big scheme of things? What we do has an impact on lives, not just acutely, but chronically. The ability of the patient to walk out of the hospital, not just the emergency room, not just our ambulance, but out of the hospital and go on to live some means of life that they lived prior to the emergency that brought them about a pre-hospital provider. So that's the goal. That's what we're doing. And all that's from research. So we dump our patient care report information into national systems. We dump it into state systems, all with the hope that that data will go forward and produce better outcomes for those patient populations, and that pre-hospital care would have been responsible for actually improving the overall mortality and morbidity of patients that we see. So that's why we do all the research we do. We also know that public health is a really important thing for EMS to engage in. The fire service did a really good job with this, so well, in fact, that people stopped burning down their houses in droves. And so if you look at the statistical averages of fire agencies today, the bulk of their responses are EMS driven, not fire driven. Why did that occur? Well, it's because of coding. It's because the fire service got heavily involved in construction methods and modalities. They got heavily involved in producing legislation and regulation that would result eventually in less structural fires, in less life lost and property lost from fire. And so we learned from the fire service and said, EMS can do that too. EMS can take the most severe emergencies that we see, the most common emergencies that we see, and we can attack them from a public health standpoint in an effort to prevent them, and if not prevent them, respond to them in such a way that the outcomes are bettered when they weren't before. And so when you think about putting EpiPens in the gyms, putting EpiPens in schools, elementary schools, middle schools, high schools, if you think about AEDs, they're in your gym, they're in your grocery stores, they're in your airports, in any area of mass gathering of people. We have attempted to push hands-only CPR to the communities at large so that people know when an emergency occurs, the immediate response of the public is what will or will not decide the fate of the patient. And so we wanted to engage in public health in EMS and attempt to gain some of the positive outcomes that other areas of public safety had gained in their own public health outreach. So that's what we do. Hands-only CPR is an example. Automatic external defibrillators is an example. Putting out EpiPens and stop the bleed kits. That is an example of public health outreach. All an attempt to prevent the loss of life where possible. EMS is a system. We don't work alone. So obviously we're working with police officers and firefighters and physicians and dispatch centers. And so we are a system. We could not do what we do alone. And so it's important to realize that. You're going to come to know that you're governed by the National Registry of EMTs in our state, and you're also governed by the state of South Carolina. Typically, the strictest rule applies. And so the state has precedent. However, the state is largely advised by the National Registry of EMTs. In fact, we are a National Registry state, which means we have adopted the rules of the National Registry. Now, the beautiful thing about that is that your state does still have precedent, correct? I mean, they can take from and use and then choose maybe even not to use some. So there's a standard algorithm from the National Registry. You take that algorithm and you build upon it. And the state of South Carolina has done that. And so if you want to be an EMT in our state, you must become a National Registry EMT. As we go through the course, we are going to discuss the differences in the National Registry scope of practice and the South Carolina scope of practice, because there are some differences. And you're going to sometimes hear me say, I'm teaching you the National Registry way right now. You need to remember it. It is going to be used on your National Registry exam for psychomotor and cognitive. However, there's also South Carolina ingredients thrown in there. For example, the National Registry doesn't recognize King tubes or eye gels, which are supraglottic airways, as being an EMT skill. However, the state of South Carolina says that it is. We would like our EMTs to be capable of that skill. And so because the state has the rule, they're the strictest authority, they have the rule, and so then the rule applies. The National Registry might not recognize that as scope, but we do. So there are going to be things that I teach you from an EMT perspective that belong to our state. And I will differentiate those from the scope of practice noted by the National Registry. And although that might be confusing and require a little bit of attention to detail from you, it is necessary. There are differences, and those differences must be known to you. So we'll discuss those throughout the entirety of the course. After you pass the class, which you will do cognitive exams for and psychomotor exams for, you go on to do a psychomotor exam and a cognitive exam for the National Registry. So if there are questions about that, please let me know. The next big question we're going to answer in the course is, what is the difference between EMR, EMT, Advanced, and Paramedic? We should start with EMR in the regards that the state of South Carolina does not recognize EMR. They do not exist. We only have EMTs, Advanced, and Paramedics. And so you might say, but Justin, every firefighter agency that I know has EMRs. Yes, they do. But they're not recognized. They can't write patient care reports. They cannot conduct any type of patient care that would be documented as a provider level in our state. That doesn't mean that they're not necessary. It just means that our state says we will begin provider level at the EMT level. So there you go. So what is an EMR? Basically, an EMR is a very small step up from layman. They can take vital signs. They can do anything a layman can do. For example, a layman can give an EpiPen if it's an auto-injector, if it was on the wall of a gym. If there's an emergency anaphylaxis kit as a public health outreach point on the wall of a gym, and any old citizen could deploy it, then so could an EMR. Excuse me. So, an automatic external defibrillator, an AED. That's designed to be used by laymen. So then an EMR could deploy an AED. But an EMR could not do a supraglottic airway. They're not supposed to do blood glucose checks. They can't give any medications from a bag. So you couldn't put the EMT medications in a bag and an EMR give any of those medications. That would be reserved for EMT. So that's an EMR. Basically, they can check vitals. They can do compressions. They can use an automatic external defibrillator. That's an EMR. EMT is where the training actually begins in formality. An EMT typically has about 200 hours of training for the course to count in the National Registry, and for sure in the state of South Carolina, it must be at least 200 hours. And the thing that differentiates EMT most is that it is the first level of assessment. The foundational assessment is learned by an EMT. They know how to process the scene. They know how to perform a primary exam. and they know how to perform a secondary exam. That is a very big foundational component that sets EMT apart from EMR. They can give quite a few medications on their own accord. Aspirin, nitroglycerin, albuterol, Narcan, activated charcoal, epinephrine by intramuscular injection. So they can give quite a bit of medications, and not medications that are found in the public health domain, but medications that they have medical control physician authority for that were put into their own bag of response tools, and so that differentiates them again. The advanced EMT differs from the EMT mostly in the fact that advanced EMTs can gain intravenous access. So basically IVs. Anything starting with IVs and above is the advanced world. So an EMT can give intranasal medications. They can give oral medications. They can give medications that are inhaled, like albuterol and oxygen. They can even inject medications into the muscle of a patient. But they cannot give any medications intravenously. They cannot give any medications intraosseously, which means into the bone. Once you access the venous system, vascular access, which covers both veins and bones, we can drill needles into bones, or we can put a needle into a vein and give medications in through both of those access points. That's where the advanced differs from the EMT. So EMTs don't start IVs. Advanced EMTs do. I apologize for the cough. I'm on the better side of this, even though it might sound like I'm dying. I'm on the better side, apparently. So that's the difference between an advanced EMT. And they can give quite a bit of medications through the IV, the most common of which would probably be dextrose solutions, sugar. So the EMT can give oral glucose, but if the patient weren't conscious enough to be given oral glucose, they would need an advanced EMT or above to start an IV and give that sugar solution via the vessels, the vascular system. So that's what separates the EMT from the advanced, intravenous access. Then, of course, you have the paramedic. The paramedic can do 12 leads, which is pictures of the patient's heart. They can intubate. They can put people to sleep. They can put in chest tubes. They can do needle decompressions. So all kinds of stuff that you would typically see physicians doing. The big test question that you're going to see that differentiates paramedics from all the rest is intubation, which means putting in a breathing tube in the trachea. Excuse me. So putting a breathing tube into the trachea, that's a paramedic skill. That's called intubation. And EKG, interpretation. So EMTs in the state of South Carolina can put a patient on the monitor. EMTs in the state of South Carolina can capture a 12 lead, which you're going to come to learn. And if you need a visual to that, you can just quickly do a little Google and it'll show you a 12 lead. But EMTs can't read them. They can't interpret them. The paramedic can actually monitor the heart rhythm of a patient and take electrical pictures of that rhythm and diagnose emergencies based on that rhythm. So that's what separates that. If you have any questions about the differences between EMR, EMT, or advanced and paramedic, let me know. And this basically just goes through what we just talked about. You do need to know the difference between BLS and ALS. BLS is considered basic life support, and ALS is considered advanced life support. The EMR and the EMT would be included in BLS. The advanced and the paramedic would be included in ALS. So advanced and above is ALS. My apologies. And this is just going over what we just discussed. This is going to tell you a little bit about what your training will compose throughout the course. You kind of know that stuff already, but it just kind of goes through it again. Remember, your National Registry EMT license is not a license to practice. You can take your NREMT license to any state you wish to practice and say, I'm an NREMT. May I apply to be a state EMT with you? And that gives you the right to practice. So once you get your South Carolina EMT license, you have a right to practice. I'll let you read the ADA stuff in Title I. It is important to let you review that most of what we learned early on in EMS came from war. And that just made sense because we didn't see back then the conflict and the amount of trauma in civilian world that we saw in war, obviously. When you look at today, that's a little different. You have a change in civilian behavior that didn't exist 25, 50 years ago. Certainly not in the numbers that it exists today. We did not have personal ownership of weapons of war. And that's just the truth. No matter where you stand on that political argument or where you stand on the argument of gun control or gun regulation, 25 to 50 years ago, we did not have weapons owned by the general public that were capable of producing 100-round magazines. We just didn't. And we do today. And so, for a multitude of reasons beyond just the weaponry, we have seen the trauma of war bleed over into the trauma of the civilian world. Also true for the world of medicine. We're seeing people live longer. And so in the medical side of EMS, we're dealing with patients who are experiencing emergencies that they didn't used to live long enough to experience, like the amount of heart attacks that we see, the amount of strokes that we see, the amount of polypharmacy emergencies that we see, where we have elderly people who are taking multiple medications that end up interacting with one another. So on both sides of the fence, the medical side of EMS and the trauma side of EMS, we're now seeing what we only used to see in wartime bleed over into the civilian world. So it makes sense that in our early existence, most of what we knew to do in EMS came from war, especially when you think about trauma, especially when you think about using helicopters to evacuate casualties. The word paramedic means beside the physician. And in war, you literally had a group of paramedics around very few physicians who were extensions of that physician's hands, who would go out into the field and do what that physician had trained them to do. And that very closely resembles what we have today in EMS. In today's EMS, we have providers, EMTs, advanced, and paramedics who go out into the field and are an extension of the licensed physician that oversees the service. And so we are still today beside the physician, the word paramedic. You need to know that the Department of Transportation was the first governing body of EMS, and that makes sense because we move things, and the Department of Transportation dealt with moving things. And so we have always been, and still remain today, underneath the Department of Transportation. EMS is only as old as the 70s. We really began what you would consider EMS in the 70s. Around 1973 is when we passed the first federal regulations or the federal act that involved the idea of civilian emergency medical response. So you kind of got to remember that. Department of Transportation and the 70s is kind of where we began. You can see that in 71, AOS, the American Academy of Orthopedic Surgeons, produced the first EMS textbook, and that is the book we're using for this class, produced by the same entity of expert knowledge. Now, it's heavily influenced by modern-day EMS providers. It's heavily influenced by board-certified EMS fellowship physicians. It's heavily influenced by emergency and critical care board-certified physicians. But it is still coming from the original source, which is really cool to see transition through time. So, although we are under the Department of Transportation, the Department of Transportation did eventually go to the government and say, we know a lot more about tractor trailers than we do about moving people who are hurt, injured, and sick. So we need a little more governance. And so that's how we found ourselves furthermore placed under the National Highway Traffic Safety Administration. And so currently, the national EMS response is overseen by the National Highway and Traffic Safety Administration, whom is governed by the Department of Transportation. So you kind of need to know that. We already talked about the fact that there's federal guidance for EMS, there's state guidance for EMS, and then there's local. And the strictest rule applies in most cases. And so let me tell you what that really means. So, example, the federal level says that EMTs don't do supraglottic airways like King tubes. Well, the state of South Carolina says that it does. So then we did. But if the medical control physician at your service says, I really don't want my EMTs doing that, I'd rather my advanced EMTs do that, then the strictest rule would apply. And so the local level rule would apply. Your medical physician has the most authority over you in most cases. Here's where that's not true. Say your physician wanted to give the EMTs of their service the right to do IVs. Can't do that because it's conservative based. So the local strictest rule applies. And so you can't go up, you can only come down. Does that make sense? You can be more conservative, but you can't be more liberal. So an EMS physician can't necessarily give more to the service, but they can kind of come down from the scope allowed by the state. One of the normal ways you'll see that is some services don't RSI. They don't put patients to sleep. RSI means rapid sequence intubation or rapid sequence induction. And what that means is to take a patient who's awake and conscious and put them to sleep and put a breathing tube in. There are a lot of EMS physicians in the state that say, I really just don't have the training officer for that. I really just don't have the oversight and the governance that would make that program safe. And so then I'm not going to do that. And so then the strictest rule would apply. The medical control physician had the strictest rule, so then it would apply. That's how that works. If there are any questions about that, let me know. Remember the difference between BLS, basic life support, and ALS, advanced life support. I'll let you read that. We kind of went through all of that. I'll let you read those hours of training. You know that the paramedic is the most hours out of those options. You do need to know that the 911 system is called public access safety, or access to public safety, or we call them public safety access points. Regardless, when people have an emergency, they pick up the phone and they dial 911. And you need to remember that we don't just send responders. We also start care from the point of the 911 caller. And that's called EMD, Emergency Medical Dispatch. We know that emergencies are sensitive to time. They're sensitive to time. So if you're going to make the biggest impact on a medical emergency, you need to start care from the time of onset of symptoms. For example, cardiac arrest. If you're going to save a patient who goes into cardiac arrest, you must begin care immediately. We know that the brain begins to die in about 5 minutes. If that's true, then you could not wait the average 7 to 12 minute response time that you would see for police, fire, and EMS. You don't have 7 minutes. So how do we bridge the gap? How do we connect the patient to the highest chance of a successful outcome? The answer is begin care from the point of the 911 call. The recognition of the emergency should then be the immediate point of beginning care. Medical control is the same thing as medical direction. You need to know that everything EMS does, EMTs, advanced, and paramedics, is because a physician has put their license on the line for us. A physician has said, I give authority to these EMTs to do their job as an extension of my hands and of my mind, assessing the patient and determining the necessary interventions. That's how we do what we do. That's called the medical director. It's also called medical control. You need to know it as both words. Medical direction and medical control have two versions of telling us what to do. We have standing orders and protocols that are offline, and we have online medical control. So you have offline and online medical control. Offline medical control means that there's no physician present, no one's talking to a physician in any way, shape, or form, but we're doing our job. That would typically come from standing orders, guidelines, and protocols. If you have online medical control, then you are somehow interacting live, real time, with a physician who's providing oversight for your care. So med control has two versions: offline, which is when we're behaving on our own accord, and online, which is when we're doing what we're doing because a physician is telling us to do it. Know the difference between those two. Obviously, we integrate ourselves aggressively with the trauma centers, the cardiac centers, the stroke centers, because whatever the leading edge of care is in any special part of medicine, heart attacks, stroke, sepsis, trauma, obstetrics, pediatrics, whatever the care is at the tip of the spear for that population of patients, we get that information from integrating ourselves with the facilities that do that best. So if you want to know why we do what we do about trauma, well, we went to Trident, which is a trauma center. We went to MUSC, which is a trauma center. And we got with the board certified trauma physicians and we said, what should we be doing for this emergency, that emergency, that emergency? And they tell us. And so then we write best practice guidelines based on that integrated care. You guys know that we do all of our patient care reports on computer systems, and that information dumps into a multitude of data storages that are assessing the outcomes of pre-hospital care. We are going to evaluate every call, and it's not supposed to be negative. It is supposed to be positive and growth-based. Just culture means that employees are held accountable by an understanding that systems matter. If an employee makes a mistake, it's not typically that it's just an employee mistake. What about the systems available to the employee? Did the policies and procedures have an area of weakness that allowed for the mistake to be made? It basically brings about fairness and accountability. So that's just culture. Just culture tries to make the service fair. That it's not just a people problem, maybe it's a policy and procedure problem. Obviously, patient safety is a big deal for us. We do bill for our services, but the physicians that are in our services are not billing for our services. So a physician med control, a medical control physician, cannot bill our patients. So they don't need to know the patient's insurance information. Now, the agency can, but not the physician. Obviously, you're instructed by EMS instructors who go on to get bachelor's and master's degrees, and then they have to certify as instructors through the state. And so, for example, in the state of South Carolina, I had to satisfy a lot of hoops to gain additional blessing as an instructor for EMS. And so most of your instructors have gone on to at least get a bachelor's degree, if not a master's degree, and then they jump through a set of hoops to get approved as individual certified instructors for that level of medicine. So, for example, I had to do one for EMT, I had to do another one for advanced, and I had to do another one for paramedic to become instructors in all of those modalities. After you finish with this course, the learning is not over. Every 2 years, you must recertify, and you must recertify by validating your continued education. And so, once you certify, you have to keep recertifying every 2 years or it goes away. And why is that? So that we make sure the learning continues. Because what we do changes very often. We are constantly assessing the data to see what works, what is successful, what's not successful, and then we put out policy and procedure. So if you're not doing a continuing education program, then you'll probably be doing the wrong stuff. You'll be doing the old stuff. And we all can name a few people that we know who are still performing 2005 paramedicine. So you want to not be that person. Already talked about EMS research. Those are all the responsibilities of an EMT. We are members of the public, serving the public, and so we are to look professional, and we have a lot of requirements on us that aren't necessarily requirements on other jobs. And my take on that is, if you don't like that, then do another job. But we are public servants, and so the public gets a say in what it is that we look like, how we behave. They are funding the services that we are providing. And so then the requirements on us are quite a bit different than the requirements on other agencies and other types of jobs. You guys know about HIPAA. HIPAA is the Health Insurance Portability and Accountability Act. You need to know what the abbreviation HIPAA stands for. You're going to see that. You need to also know that it basically protects personal information of our patients. We're not allowed to tell anyone that XYZ patient received care for XYZ problem. You can never share that information. So, you already know that, but every year, EMTs, paramedics, physicians, nurses lose their job and potentially get legally in trouble for violating HIPAA. So make sure you know that the information of our patients is very protected. You can't share it. At the end of every chapter, you'll see about 10 questions. Some chapters, very few, have a little bit more than 10, but most of them have 10. And so we'll go through these, and yes, you can cheat, but I would implore you not to cheat and to actually go through the questions with us. For, if nothing else, learning the system of how EMS testing works, because it is its own animal. You're going to come to know that there will be multiple right answers in most of these questions. And so as we go on through the course, you're going to learn to pick the most correct answer. So if for nothing else, you're practicing how to take the test as we go to the end of each of these chapters. So question number 1, which of the following is an example of care that is provided using standing orders? We remember that standing orders is one of the 2 options of medical control. There was online and offline. So standing orders is offline medical control. And so we're looking for which one of these would be an example of offline care. So A, medical control is contacted by the EMT. Well, no. If you're working with medical control, that would be online. So that's out. B, the EMT defibrillates a patient in cardiac arrest, begins CPR, and then contacts medical control. I like that one because the EMT did a lot of stuff offline. So that would be standing orders. So I'm going to hold on to B. C, a physician gives the EMT an order. Well, if the physician gave a direct order, that's online. So then C is out. D, following an overdose, the EMT contacts medical control. Well, again, if you're working with medical control, that would be online. And we're looking for an offline option. So then I have to go with Bravo. B, Bravo is the only one of these 4 answers that is mostly done offline using standing orders. The EMT did a lot of care in this case, in Bravo's case, without a physician helping them. So that would be standing orders offline. Bravo. Quality control in an EMS system is ultimately the responsibility of what? So we remember that quality control is about the patient care, measuring the outcome of the patient care. Who is most responsible for our patient care? And the answer to that is Charlie, the medical control, which is also the medical director. The physician is most in charge, most responsible for the care that results from an EMS system. So then the answer would be Charlie, medical director. Upon arriving at the scene of a domestic dispute, you hear yelling and the sound of breaking glass. What should you do? Well, we discussed in the material that your safety comes first. You are not supposed to run into danger because you don't have a gun, You're not wearing bullet-resistant vests depending where you work. So you're not supposed to be in harm's way on purpose. And so the answer to this question would clearly be Charlie. Retreat to a safe place until you can get police there, because they do have guns and they do have bullet-resistant vests and you don't. So if the scene becomes unsafe, get out. Charlie. Which of the following is not a component of CQI? CQI, again, continuous quality improvement, is the review of our patient care reports. So periodic review of run reports. Well, yes, that's CQI. Discussion of need to improve. That's for sure CQI. Negative feedback given to those who make mistakes. We very clearly said that CQI was not supposed to be punitive. It was not supposed to be a judgment. It was supposed to be improvement. It was supposed to make sure that we're providing the tip of the spear, the best care possible. So Charlie is not a component of CQI. All of the following are responsibilities of the medical director, which we know is the physician, except which one's not a part of the doctor. Evaluating patient insurance information. Well, that's already a red flag because EMS physicians are not supposed to bill for the care that patients receive in the pre-hospital setting. So then alpha is probably our answer. But let's go on. For good test-taking habits, let's look at the other answers. Bravo says serving as the liaison to the medical community. Well, certainly the physician is that. So B is true. Ensuring that the appropriate standards are met by the EMTs. That's also true. That's a job of the doctor. Ensuring appropriate EMT education and continuing training. The EMS physician is ultimately the head of the education and continuing education program at any EMS agency. So B, C, and D are indeed jobs of the EMS physician. But alpha is not. So alpha is the answer. Which of the following situations would most likely disqualify a person from EMS certification? Misdemeanor committed before you were an adult? Nah. Driving under the influence. Always going to prevent you from being in police, fire, and EMS. B, Bravo, is one of the surest ways to lose your ability to be in this job. They hold driving under the influence in the same category as they hold beating your spouse. So if you get a DUI in this job, you're out. Pretty much exclusively. So Bravo is going to be my answer. Which of the following should be the EMT's highest priority? Bleeding control, maintaining an airway, patient safety, your own personal safety. And we know that the answer to that is your own personal safety. A patient who requires cardiac monitoring in the field would require, at a minimum, which EMS provider? Now, this is tricky because in our state, an EMT can put a patient on a cardiac monitor. They can put on a 12 lead and take a picture of the patient's electrical cardiac activity. But we very clearly said that they are not allowed to actually interpret it. The word monitoring means to interpret the results. So if you're going to interpret it, if you're going to read the rhythm, you got to be a paramedic. So the answer would be Charlie. Which of the following is a professional responsibility of the EMT? Telling the family of a dying patient that everything will be okay. Well, EMTs are supposed to always be professional and honest. And so sometimes everything will not be okay. And so then A can't be the answer. We have to be honest with people. Bravo says maintaining only the skills that he or she is uncomfortable with. Well, no. You need to maintain all of your skills. So Bravo's out. Charlie says maintaining a professional demeanor in even the most stressful situations. It is true that EMS is supposed to bring calm to chaos. It is probably the most honorable skill that an EMT can have. Your ability to remain calm and present decisive order to chaos is one of the most sought after attributes of our profession. So I'm going to go with Charlie. Maintaining professional demeanor in very stressful situations is absolutely the professional responsibility of an EMT. Emergency patient care in progressive phases. What occurs first? The answer to this is in the slide presentation. So it basically goes through an EMS call. Well, what comes first? Well, you got to recognize that an EMS call exists in order for an EMS call to be made. So Delta is going to be my answer. The first thing that would occur in the progressive phase of an emergency is that we recognize one exists. So I'm going to go with Delta. Once we recognize it, then we would activate EMS via the public safety access point. Then we would begin pre-hospital care. Then the patient would receive definitive care. Definitive care means the care that would resolve the emergency in its totality. So sometimes that's one or two things, and sometimes that's following the patient the rest of their life. So definitive care for a heart attack, for example, would be if the patient received a stent in their heart artery to open up the blockage and let blood go by, and then the artery wouldn't close again. That would be definitive care. We are pre-hospital care, and the complete resolve of the patient's emergency is definitive care. And that will conclude chapter 1. So we will come back in 10 minutes. 10 minutes from now. So the recording is timed in minutes. And so if you come back in 10 minutes, you'll hear me talking again, which is super exciting for you, I am sure. So I'll see you back in 10 minutes. Alrighty then. As promised, about 10 minutes. Let me just double check that all things are in order. Your microphone's not working. Connect to a different device or try something. Reconnecting to this one. Well, that one sucks. I hope my microphone's working. That would be really sad if it's not working. Really sad. Why is... Okay, kids, let me stop here because it's saying my microphone's not working. Let me make sure that that's not true because I do not want to continue on recording this lecture if that's the case. And play it back and see if it's working fine. So give me a second here. I'll be back.